This conference will now be recorded.
So, what I wanted to say before we get started is I just wanted to plug two meetings that neither of which may apply to too many folks on this call, but you may know people who would find them very helpful. And the simplest one is that, as we've mentioned, we're starting an active surveillance call, but that is really active surveillance for people with low-risk disease. As I mentioned in my email this week, we often forget that there are many men doing active surveillance with more complex disease, like, for example, Len or Peter, when they're on their break, if they're on intermittent hormone therapy, during that period that they're on their break, they are really following active surveillance protocols. And we sort of tend to forget those guys when we talk about active surveillance, and also the guys who have recurrent disease or think they may have recurrent disease and are watching very carefully and, again, following active surveillance protocols. There was a fellow like that on the group, on Peter's group last night. But what we're starting, and it'll be to begin with the first Wednesday of every month, is an active surveillance group for people like Howard Walensky, who are truly, or Ken Mason, who truly do follow active surveillance. And it's going to be moderated by Ken and Mark Lichty, who is a eminent person in PCRI, and also started the Active Surveillance Prostate Cancer International, or ASPI, who at one point thought they were going to have a big conference on active surveillance this year. That starts next Wednesday. So if you know anybody that's on active surveillance and you want to mention it to them, it would be great to help spread the word. The other meeting that we are about to hold on Monday night, which is a fifth Monday, so it gives us an excuse to do a plenary, is going to be on the 9/11 victim compensation fund, which was established by the government after the towers collapsed. And I've sort of heard this presentation once before because the Male Breast Cancer Coalition did a session for their people, and I felt that it needed a much wider message. So we said, okay, we'll take it on and we'll try and spread the message. And the reason being that, this is what I didn't really know until I listened, there were some 300,000 people affected within the New York boroughs, according to the definition created by the Victims' Compensation Fund, and there were 150,000 or more first responders who came from all over the country. So, and a lot of the 350,000 who were in the New York area have since left the New York area. So
Rick, you froze.
Yeah. He's been having problems with his internet connection. He was freezing up the other night too.
Yeah, it's been a pretty consistent problem, but this is the worst.
I think last time he actually gave up and just hung up, or maybe he called in by telephone. I'm not sure what. Yeah.
I guess he can hear
eligible
us.
for a small. Can you not hear me?
We didn't hear you for a good minute there, Rick.
Sorry?
We did not hear you for a solid minute. Now we can hear you right now. Yeah.
Okay.
Apparently you couldn't hear us either because we were telling you that you froze.
Right, I didn't hear you. So let me try again.
Well, the last we heard was 150,000 first responders, some of whom left New York City.
Okay, all right. So let me go back. It might be that this is this doubles up on the recordings, in which case for anybody on the recording, I will apologize who listens on the recording, but what just happened is that you lost me. So yes, there were 150,000 first responders. So with 150,000 and I'm going to turn off, it's telling me to turn off my webcam, so I'm just going to do that for the time being. The others,
Okay.
The rest of you can stay on, but I'll stop sharing my webcam and hopefully that'll solve it for a while. So there's probably 500,000.
What was that? We missed it.
I said Len and I are the prettiest ones anyway.
Yeah, that's right.
Especially
So
Len.
there are 500,000 people spread across the country who may be eligible, and for a whole variety of conditions, ranging from all kinds of various cancers to various respiratory diseases. And some respiratory diseases as mild as sleep apnea. So if you have sleep apnea and you happen to live in Brooklyn or the lower half of Manhattan, then you might be eligible for compensation. So what if you know anybody, any first responders? I just ask you please to get this message out to them that we've got a plenary at 8 o'clock Eastern on Monday, and it'll be about an hour long, and we will be, that's what we'll be addressing. Michael Barash, who's an attorney, and Robert Bard, who's a doctor, both of whom are highly experienced. So, okay. We have someone else who arrived on the telephone. Who might that be? Someone on the telephone who just came in a few minutes ago?
Yep, that was
Sorry
me.
about that. It's Jerry Pelphrey.
Oh, okay, Jerry. You don't have to be sorry. We are very happy to welcome you. I'm glad you're on the call, Jerry. Okay, so let's get down to business. We don't really have anybody new, but we've got at least one person who has not been with us for some time, who I'm delighted to see, Alan Bold. Let me go down the list and see who would like some.
We lost your audio now too, Rick.
Maybe he needs to phone in.
Yeah. You want to take the roll call while we're waiting for him, and then you can tell him who wants to talk?
I might as well. Okay, so, well, let's start with Brother Jake. I think you managed to weasel out last week, I think.
I was ready, you know.
Yeah, yeah, it's true. Okay. Sometimes Rick gets a little backed up.
Well, as he said, it was a pretty full call last time.
Yeah. All right. Next on my list, we have Alan. Would you like to talk about anything tonight, Alan?
Basically, I just want to listen because it's been a while since I've been on the phone to you guys, and I think it's better I just listen.
Okay.
Okay, can you hear me now? I think I'm back. I was just about
Yeah, we
to
can
call
hear
in,
you.
but I think I'm back. Alan, would you be maybe willing at least to give us a little update on how you're doing?
Yeah.
Okay.
I've been on chemo since last summer, and I went through Zytiga, and then I went through Xtandi, and then the chemo. What two chemos am I?
First and second line chemo.
First and second line chemo, and I'm on Jevtana right now, but they told me it's not working. So.
So let me come back to you in one moment because we've got some ideas and we'll just do a quick roll call and then we'll come back to you and we may have some ideas for you.
Okay.
Hey, Rick.
Good.
Let's just interrupt for a moment to let Jake know that your mouth was moving, Jake. I guess you were trying to tell us something, but you're muted.
Yeah, I realized that after I was done. I was asking Alan to hold up. But that's
Okay. All right.
Rick.
Okay.
Okay. So let me start. Jake, did you have anything you wanted to talk about today?
Not really, but Len kind of pointed out that I didn't get called on last week, so I can give you an update on my PSA.
Okay, so Jake, Len, is there anything you'd like to talk about?
I also have a PSA update.
Okay, Paul Frieda, anything you'd like to talk about?
No, nothing tonight.
Okay, Les, anything for you?
No, not this evening. Thank you.
Okay. Alan will come back to Larry Fish. Anything you'd like to talk about?
Nothing specific. There is one or two things I could mention, just the things that were a couple of interesting things I thought about, but it's okay, maybe a little bit at the end. Yeah.
No, we're going to have plenty of time today. And Jerry, we would love to talk to you to find out how you're progressing. So we'll stop by you pretty quickly and see how you're doing. And then is that Ken Anderson that's on the call? Do I see a Ken? Is that you, Ken?
That's me. That's me.
How are you?
I'm good. I'm good. I'll listen in. I don't have any updates.
You don't have anything to talk to us about?
Well, I can if you want to. I don't have any reports though, because I don't have any labs. So.
Well, that's okay, but you can still talk to us. We got plenty of time today, so maybe we'll stop by. You can think about what you want to ask this illustrious body about.
Will do.
Okay. So let me come back to Alan and Alan, let me just look at my notes on you, and we should probably just fill people in that if I've got it right, back in 2010, you had a PSA of about 2,300. Is that right?
Yes, It's about the same now.
But it did go down in the interim to as low
Yeah.
as 0.1, did it not?
Yes, it did, and I wish it would do it again.
Well, I'm actually raising this for an important reason, because we have a man on the call tonight who you talked to recently who just got diagnosed with PSA over 3,000. And I think it's important to let some of people like that know that the treatments can work. And then, yes, it goes back up and we do more treatment. But I think it's encouraging to somebody to hear that back in 2010, which is 9 years ago, you were diagnosed and you're still with us and you're fighting the good fight. Isn't that true?
Yes, and I'm not done yet.
Thank you. That's what we want to hear. So, the last time we spoke to you, if I'm not mistaken, my notes say was back in March of 17. So it's about 2 years ago. And you were considering chemo, but you were doing enzalutamide. And tell us a little bit.
That's Xtandi, yes.
That's Xtandi, correct. And since then, you've gone through Docetaxel and Jevtana.
Yes. Yeah, and that worked good at first. I'm still on it. They're still giving it to me. But I have a hunch they're going to take me off soon.
Okay. And where are you getting this? Is this from University of Chicago or somewhere else?
No, we work together. Both doctors are agreeing on what to do. So I'm having it done out in the suburbs.
Okay.
They're a little bit perplexed with me because my bone scans show that I've improved. The bone cancer has gotten better in the bone. But the PSA keeps going up. So they say we're just going to forget about the PSA for a while.
Have they sequenced your tumor? Have they sent the tumor off to get it analyzed for genomic description?
Not as far as I know, no.
So I do think that if it were me, that's what I would be looking to do right now. I would be very eager, especially because if the Docetaxel is no longer working, but the Jevtana may be working, and because you can't seem to find the right key, there may be a clue. And you are eligible on Medicare to get that tumor analyzed. And I would be asking either Stadler or your local doctor to send a sample off, probably to Foundation Medicine. And it's
to where
easy
Foundation?
Foundation Medicine. Yeah.
Foundation Medicine.
Now, the only issue is what are they going to send off? And ideally, what they need is a sample from a lesion, a recent lesion. They don't want to be sending something off from 2 years ago. So right now, where does it look like you might still have bone lesions?
Around the hips,
Okay.
around the hip bone.
Okay, so that's a great location to get a sample because it's pretty safe to get a sample from there. And I don't know if there's anybody on the call has anybody on the call had a bone biopsy? Guess not. You know, a lot of guys describe it as it's not that uncomfortable because you have an anesthetic, but it's like tapping. It's kind of like the seven dwarfs tapping away at your bones. So you feel it, but you don't have any pain. You're aware that they're doing something, and they do it in it's local. They do it in the radiology suite. It's what they call an interventional radiologist who does it. And what they'll do is they'll take a sample of the tumor, and then they send it down to Foundation Medicine, who has a lab they have a lab in Boston and a lab in North Carolina. They send it to them, and they will analyze it and come back, and they will then tell you whether you have any unusual mutations. And if you do, you may be eligible for some of these fancier drugs that are out there. My feeling is, especially since they can't seem to figure why your PSA is not going down, that it might be a good way to go. Do you have any evidence of metastasis in any of the soft tissue in your liver or your lungs or anything like that, any place like that?
No, thank God.
Okay, I agree. So that's certainly one thing. How quickly has that PSA been escalating?
The last couple of weeks.
Just with Jevtana.
Sorry, say that again. Just
Jevtana, maybe the last.
Just the last couple of weeks with the Jevtana.
Okay. So, you know, if you're back up to these numbers and it's moving quickly, now would be a really good time to get that bone biopsy and send the bone biopsy to Foundation Medicine. Len, did you want to add anything before we open it up?
I was just thinking it might be worth getting the liquid biopsy first, and then if that comes up negative, go ahead with the bone biopsy. But if the liquid biopsy came up positive with some actionable genes, then he can save himself the expense and trial of the bone biopsy.
What's the liquid?
Well, it's basically a blood test where they pick up cell-free DNA, tumor DNA in your bloodstream, and they analyze that.
Oh, that's good. Well, I've got this all written down, gentlemen.
Your wife does.
Yeah.
My wife
So
does.
yeah, but the only disadvantage with doing that, Alan, I'm pretty familiar with Foundation Medicine. I actually I sit on their patient advisory council, community council, and they're a very good outfit. Is that if you can get a bone biopsy, the results are a lot more reliable than the blood biopsy. The panel for the blood biopsy is significantly smaller. It's around, I don't know what it is now, but it's somewhere between 75 and 90 mutations. The panel for the bone biopsy is about 360 mutations. Probably most of the actionable mutations, meaning the ones that we know that drugs will work for, are included in the blood biopsy, but the technique in extracting the DNA from the blood is nowhere near as reliable. So blood biopsies are fine if you cannot, as a backup, but if you have the option and you are fit enough and you can get a bone biopsy, I would always recommend a bone biopsy over a blood biopsy. But that's for me. I mean, if it were me, I would be, and they could take bone tissue, I would say take the bone tissue rather than the blood tissue for me to get the best result. But you should be discussing this with your doctors.
Okay.
We're going to do that. Now, what drugs would be available if they found that they could do something?
Oh, Len, you want to answer that one?
Yeah, well, of course, it depends on what biomarkers they find after they do the genetic testing. You could be eligible for drugs that work against DNA repair deficits, drugs like olaparib, which is effective against BRCA1 and BRCA2 mutations. There could be some mutations that would indicate some of the immunotherapy drugs might work, like Keytruda, pembrolizumab, or Opdivo. I'm just throwing out names that will probably only confuse you right now. And the only take home you really need to know is that there are probably, maybe 5 or 6 different therapeutic modalities that they could use depending upon what they find.
They're thinking of, my doctor's thinking of going back, I guess, 9 years and starting over again with the old drugs.
Like what?
Casedex. Just with a couple of different.
Which the drugs that originally gave me it gave me freedom. I had no real sickness for the first 2 years.
Well, but you see, we've had this discussion with another guy recently. You would be, if you were to come off and go back to an anti-androgen, then I would say try, if it were me, I'd be going for apalutamide, which is a new drug and is a much better form of Casedex. And because if you're going to be sensitive to Casedex, you're going to be sensitive to the apalutamide.
Do you know how to spell
apalutamide? Yes, I do. Well, let me give you the commercial name. It might be easier for you, okay? The commercial name is Erleada. That's E as in Edward, R as in Richard, L as in Larry, E as in Edward, A alpha, D David, A alpha, Erleada. And I think that somebody like Walter Stadler, and I would be conferring with Stadler again right now, make another appointment, go and see him, because I doubt very much whether he would be happy seeing you go back onto Casedex, but I do understand why they're doing it. I mean, we have a guy who is doing and getting results from bipolar androgen therapy. Are you familiar with bipolar androgen therapy, BAT?
No.
BAT.
So that's a therapy where they give you large doses of testosterone and then they stop and they follow it with either the hormone therapy, regular old hormone therapy drug, which you're probably still on, Lupron or something like that, or one of these anti-androgens. And the idea is that big doses of testosterone will wake up the androgen receptors and refresh them so that they're receptive to the drugs. And sometimes it works. We don't think it works for too long. That's the problem. People that we've known who have done this, they haven't gotten a lot of out of it. But I mean, Len, well, let me open it up to everybody else. Who else would like to give Alan some input? No one?
If no one's chiming in, I'd just like to ask you, Alan, what originally brought down your PSA from 2300 to 0.1?
Zetiga.
Okay.
That was the biggest.
That was the biggest one.
Right. And how long ago did you become resistant to Zytiga?
Let's see, 2 years after Zytiga, you were on Xtandi. That was 2 years, maybe 3 years ago.
About 3 years ago.
We followed with Zytiga to Xtandi.
Okay. So you're probably on Lupron right now?
Yes.
Yes, I'm on Lupron. I've always been on Lupron.
Yeah. Well, I mean, that's what Rick mentioned is yet another option that you could discuss with your doctor, the BAT, Bipolar Androgen Therapy, which they alternate giving you the high doses of testosterone even while you continue taking the Lupron that you're already taking.
Yeah.
Thank you.
Those are great. Thank you. I'm really gonna. I really appreciate that.
No, it's a pleasure. I mean, so I think just to summarize for you, you definitely want to get genomic sequencing, either preferably with a bone biopsy, because Foundation Medicine considers that to be more reliable, or with a blood test, what they call a liquid biopsy. But if it were me, I definitely would be looking for genomic sequencing right now. Secondly, talk to your doc if they think that you need to come off of the chemotherapy, it's not working. Talk to them about apalutamide or Erleada, because that might be another alternative drug. It works a lot like the Xtandi. And lastly, talk to them, and I would talk to Stadler about this. You might get a better response than from your local community doc, but I would talk to Stadler about BAT. And if you want to know more about BAT, you can find a whole presentation on our website. If you search, I think this will work. If you search for BAT or Bipolar Androgen Therapy, then you should come up with a presentation that explains what that is all about. But your doctors will know about what it is.
Great.
Okay, I mean, that's great. I appreciate it so much.
It's a pleasure. Well, we don't want you to be a stranger, Alan. I worry about you. I wonder how that Alan Bold is doing. And now we hear your voice. We love it. And come on and talk to us. You know, come on and talk to us every so often. Okay.
Okay, thanks.
Pleasure.
Hey,
and, if you've got any, go ahead, Len.
Yeah, I was just going to ask Alan, so I think this would be of interest to guys on the call, interest to me. you've had both docetaxel and cabazitaxel. Could you just give us an idea of the different side effects you experienced, and how each drug made you feel? Did you feel better with cabazitaxel than you did with docetaxel, or vice versa?
First one or second one?
I think better with the first one, although my hair fell out. On the second one, the hair stopped falling out and it got curly.
But you're eating.
But I'm eating, so I wasn't eating with the first. Yeah, this one I'm eating. So, but it's you get pain. You know, you get stomach aches, you get aches and that. But they've given me pills to help take care of that. And so if I take that and stay ahead of the pain, it's not too bad. I'm able to function.
Which is better? Which was easier for you?
The better is the second one, Jevtana.
Right. And did you have any neuropathy with either drug?
No.
Oh, good for you. All right, thanks, Alan.
Okay,
Thank
you're welcome.
you. And thank you, Mrs. Allen, for being right
You're welcome,
there.
Rick. You're welcome.
Thank you for taking care of him, keeping track of him. And, you know, without you, I don't know where we'd be. I don't know where he'd be,
You're
and we wouldn't have
correct.
the information.
You're correct, because I even have to dial your number up, Rick. This is pretty sad, right?
Well, that's why we
Thanks,
love
guys.
you, caregivers. I do
Yeah,
want to
thank
take
you.
Probably can make it to a show, yes.
Yeah, and I do want to tell you that Mrs. Bold, what's your first name? I don't have a record.
Donna.
Sorry, say it again. I missed it. Say it again.
Donna.
Donna.
And
Got it.
yes.
Got it. Donna, we have a caregivers group. If you would like to come on it, you might find it very helpful. And
Yes,
we'd love
and
to
I
have
saw-
you on it.
Wonderful. Is that the support group?
Yeah, we have we have one, and us too has one, but ours is more regular. Ours meets every first and third Tuesday at 7 o'clock Central.
Okay.
And,
Will we get emails on that, Rick?
Yes,
Will
I'll
we get
make
an
sure you
email
do.
when the-
You know what? Of course I know your name, because I have aladonnab@aol.com. Of course, I should have looked at that. So I
That's
know.
okay. That's okay. Thank you.
Okay. Yeah, I'll make sure that you're on that list, Donna, and
I
come and join us
appreciate
on that call, and I think it could be good support for you, and we'd love to have you on that call.
Thank you so much.
Okay.
I'm looking forward to going to. Okay, thank you for helping us out here, Rick.
Oh, it's a pleasure. So I'm going to go to Jerry next. Jerry, is that you again as on caller 03? Jerry?
I got cut off.
Okay, yes, I thought that might be you. Okay.
Yeah.
So I thought it might be you. So Jerry, give us a little update on how you're doing with this treatment, where you're going. I hope you heard that here was a man who was diagnosed with a PSA of 2,300 9 years ago.
Right. I heard that. I'm also wondering how much information do you have on the the other cancer, prostate cancer cell, which is called the killer cell? And is there any thing he could do with something like that? Is there any way to prove that he might have killer cells rather than the regular cells that Lupron and ADT take care of?
So let me. I've actually never heard that expression, the killer cell, but I think I know what you're talking about, which is probably the neuroendocrine or the small cell prostate cancer.
Well, Rick, it's in Oncology Digest, July of 2008. It's an article because they're talking about something called prolactin, Prolatin, I think, or Prolactin. Anyway,
yeah. So let me just. We'll come back to it. I'm gonna let Len maybe address that momentarily.
Okay.
But I think that when they talk about, first of all, 2008, 10 years ago, is kind of prehistoric times. Just to put it into perspective, that was the year I first heard about abiraterone. It hadn't been approved, and they told us about these drugs that could kill the testosterone, kill the ability for the cancer to make its own testosterone. Because the cancer, when it doesn't have testosterone readily available, it goes into other cells and it extracts the testosterone from those other cells. And that's how abiraterone works. It stops that process. And we thought, wow, that's pretty amazing. At the same time, back then, we knew that there was another type of prostate cancer, which was called neuroendocrine or small cell prostate cancer, which was very difficult to treat and is still very difficult to treat. And we still don't have a good solution for neuroendocrine cancer. But when they're talking about that type, if that's what the killer cells are, because again, that's not a common term, but if that's what they're talking about in this article, then Alan would not have responded so well to abiraterone for many years. And the likelihood is that we would have seen some action in his soft tissue, in his lungs, in his liver, in his other organs, but particularly in his lung and his liver, which is where we seem to see this metastasize frequently with people that have a more unusual form of prostate cancer.
All right. Well, you want my history. You want to know where I'm at.
Well, hold on 1 second, because hold on 1 second, Jerry, because I just want to get Len's input on that.
Okay.
On prolactin.
Yeah, I've heard about prolactin. It must have been 5 years ago. I brought it up with my own oncologist over at Sloan Kettering. And this is something that's never really been proven in clinical trials to be of much use. And my oncologist over there, Dr. Daniel Danila, actually told me, he said, I've done some research with prolactin myself, and he kind of pushed it aside. He said it's not really helpful. Now, to get to the T cell, a killer cell. A killer cell is a type of lymphocyte called a T lymphocyte. And B lymphocytes are lymphocytes that produce antibodies that attack cancer cells or bacteria or viruses. And T cells have a direct killing effect on cancer cells, viruses, and bacteria. And when guys are given the immunotherapeutic drugs, what those drugs are actually doing is ramping up the activity of the killer T cell. So these are very important in fighting cancer. They're natural immune cells in your body. They need to first, of course, recognize that a cell is a cancer cell and not a normal cell. And that's basically all types of immunotherapies help train the T cell to identify antigens or molecules on the cancer cells. So when the T cell identifies these molecules, they know that, this is a cancer cell, and they attack it and kill it. I hope that's helpful.
Yes, yeah.
And thank you, Len, because I wasn't thinking of killer cells in the immunotherapy context. Of course, I'm familiar with them, like you said, from there, but I wasn't thinking of them. I was thinking about it being something related to prostate cancer cells. But yeah, that could be. Len, what was the purpose of that prolactin? Because I do remember talking with you about prolactin, and there's been a lot. What was the whole? Do you remember what it was all about?
I actually don't, Rick, but let me just do a quick search here on my own computer, see if I have anything retained. No, I don't. I guess whatever I had, I just deleted it because after Danila told me it's not useful. So sorry about that.
I remember. No, it's fine. I remember, Jerry, I'll have to look on my computer because I do remember we looked at it several years ago, but I just cannot remember the context. But why don't you fill the guys in a little bit on your background and tell us how you're doing.
Okay. Well, we kind of knew intuitively that I probably had cancer in January, but we weren't diagnosed until February 6th of this year, 2019. My PSA at that time at Mayo was 3,100. At that point, he put me on Firmagon. It gave me 4 shots and said, come back in a month. In a month, my PSA was down to 50, I think it was 59.2 or something. He put me on 3-month shot of Lupron. To give you the exact date, let's see, I started February 6th with Firmagon. 14 days later, I started with Zytiga and prednisone. So they're off a little bit by 2 weeks. But so I'm in my second, almost the end of my second month of Lupron and Zytiga. My last PSA, it's been continually going down, and my last one as of Friday was 6.4. So I obviously am reacting to the Lupron and the Zytiga. But I have 2 areas, C6, and then the area of T4 through T6, where I have significant metastasis. My bone scan lit up like a Christmas tree. I've got cancer throughout my whole body, and especially through my whole spine. But there again, at T4 and T6, that area is the worst area. And we're driving back. We're staying in a town outside of Phoenix. So we're driving back from Phoenix right now, where I had a proton beam treatment for the really for C6, that whole area, C6 and T4 to T6, because of the pain that it was causing. So it was a palliative radiation treatment. And that's quite honestly where I am. The next time I see Dr. Singh is June 10th. I'm seeing my local at where we're staying. I'm seeing my local oncologist next week, and I'll fill him in on all of this. But that's about the extent of where I am right now.
Well, I would say that the fact that you're responding so well to the hormone therapy is very good news. It's coming down. It's coming down well. That's pretty much what happened with Alan. And he too was on Zytiga. And the question is, how long can we manage the disease with Zytiga, abiraterone, and to milk everything you can out of that, since that seems like a good alternative for you. And then again, your disease may need sequencing, should be sequenced, but maybe the time to sequence your disease is when the Zytiga stops working at this point. I'm not sure.
Well, remember, Singh has already sent that off.
Oh, that's right. That's right.
Yep.
That's right. You did mention that. And
Yep,
you don't have the results back yet.
No.
Okay.
Are you there?
Okay.
Oh.
I am. Yes.
Yeah,
I can hear you. Yes.
Yeah, I don't have the results back, and I guess that I don't know how long they take, or whether he's just waiting for the June 10th. But let me tell you also, in this 2.5 month process right now, I also am a vegetarian, and I've gone totally organic. I went organic immediately on February 6th. And on top of that, I use marijuana, CBD and THC. And I don't overuse it, but I do use it, and it does help with the side effects. So that's the total extent of what I'm doing right now.
So I just want to come back on a couple of things. If I remember correctly, what I think they sent off was for the germline testing, because both your parents had pancreatic cancer. Is that right?
Yeah, it was germline. It was a genetic, right?
Right. So that he should have back, and you can ask him. You can send him a note and ask him for that. And I guess what we were looking for there was whether you might have anything in the BRCA line. And if you did have something in the BRCA line, then it might be a reason to add another drug right now. So, I would be on top of him, on Dr. Singh, just to find out where you stand on that. How long ago did he send it away?
I'm sorry? Yeah. What? You asked how long?
How long
good
ago
night.
did he?
It's a month. A month.
He should have those results back. And I would ask him for a copy of the results, and we can talk to you about them, see what he says, but certainly get a copy of the results for the germline testing.
Okay. Yeah, I can do that.
Yeah, I mean, I would certainly encourage you to do that. As far as the CBD is concerned, we encourage men on this call to speak to their doctors about the use of medical marijuana, because we know how helpful it can be, not just in pain management, but in controlling nausea, in helping appetite, and all the other things. So we really do endorse that line. And I'm glad that you're getting some relief out of it. I think we mentioned to you that you might want to get a palliative care doc on your team. Did you follow up with that?
Yeah, we haven't. We've just started looking at that for here in Prescott, where we are staying. Okay. And by the end of this week, we should.
Okay. Okay. Yeah. I mean, again, it's very good to have a good palliative care doc on your team, because they understand. They're the sort of people that are going to understand the use of CBD. Not that the good GU medoncs don't, but I don't think they have as much background. So let me open this up again. Who would like to talk to Jerry about his treatment and the success he's having in seeing the second-line hormone therapy and the LHRH drive his PSA down? Boy.
Rick, I have a comment about the CBD and the pain. There's an article in Pain Magazine, I believe, that I got a notice of today, where they say when used in conjunction with an opiate, it makes very little difference. But that has nothing to do with side effects. I'm just talking purely about the pain. But according to this article, there's not much of a benefit for pain with opiates.
Yeah, I saw that too, Jake, and that surprised me, because I thought it was kind of there was a general consensus that cannabis in combination with opiates is effective in treating pain, and it allows people to use a lower dose of the opiate. So that was kind of a shocker to me.
Yeah, that's why I was going to post it on Facebook, and I decided not to, just for that purpose, for that very reason.
Yeah.
Well, the other thing you have to consider, though, if they're talking about just straight CBD, I don't know, that may be true, but the combination of the THC with the CBD, I said that it is, so I didn't read about opiates, but that it was successful in minor pain relief, let me put it that way. But you have to have some of the THC to activate it.
Right.
Yeah, and I also think as these...
I'm sorry, Rick.
As these guys have, both Len and Jake have said, they're only talking with respect to pain, and some of the big benefits of the CBD are in the control of nausea, in the stimulation of appetite, some of the other side effects that we know these drugs can cause. So, all right. So, anyone else want to? Do you think that the PBRT, the proton beam spot radiation, is giving you any relief? Is it? Can you tell yet, or is it too early?
No, Dr. Shields, the chief there at Mayo in radiation oncology, told me it would be, I probably wouldn't see anything for 2 to 3 days.
Okay.
But as you mentioned that, Rick, as I told you, I had the proton beam at 12:30 today, and let's see, that's I don't see anyway. I seem to be getting some muscle spasms. Has anyone had any experience with that?
Yeah, this is
Any,
Dennis. Jerry, I'm also a patient of Dr. Singh's. And
Okay.
but just to answer your question quickly about the muscle spasms, I have called them muscle cramps, or that I would get sometimes after exercise, like playing golf, and then I'd have a long drive home, and I would be, if I'm in traffic and I'm just holding that right foot, trying to stay constant on I would start to get a spasm or cramp, sort of in my shin area. And I have found a product that really helps to relieve that as well as prevent it. Just a second, let me get my wife. What's the stuff I use for my cramping? Oh, TheraWorks. THERA. Yeah, TheraWorks. Yeah, it's a non-prescription.
Right.
I use it now a lot of times before I'm going to do some exercise that I think might trigger a cramp later on, and as a preventative. And it works if you wake up in the middle of the night with this cramping or spasms. You can put it on. It's spelled THERAWORX.
Okay.
Yeah, it's available at most of the pharmacies, CVS and Walgreens and so forth.
Yeah. The reason I'm saying that is, the area that was treated, it's kind of, so my if you call it a cramp or a spasm, is more like in the chest muscle and the stomach muscle. It's kind of odd. But I'm wondering if it's got to be due to the proton therapy. I would think.
It might be. I don't know anything about that, so I won't. But I'll tell you what worked. The other thing that's worked for me for localized type spasms, like I'll be sitting holding a book up and reading a book, and all of a sudden my hands, my fingers start bending one way or the other way. I get this wicked cramp in my hand. So the other thing that works is tonic water. And you can find that, you can look that up, and they'll tell you. Some people say it's because of the quinine in there, but other people say no, it's a neurological effect that it has from the roof of your mouth to something through your nervous system. But so tonic water, not mixed with gin, but just tonic water. Seems to give you it gives me a fairly quick relief from that spasm.
So, Les Shelderup, you had 20-odd sessions of PBRT recently. Did you have any experience with any cramping?
No, I didn't. And actually, it was I had 5 weeks of it, 5 days a week, and I had no cramping whatsoever.
Well, what Dr. Shields has done is he's given me just one shot. He said, "Gee, I could bring you in 5 times, for 5 days in a row." He said, "But with you," he said, I really think we'll just do one shot. It'll be a little heavier shot than I'd normally give." So that's what he's done. So I would say I got, and he wasn't in there because I wanted to talk to him about it, but because I wanted to find out the actual dose that I was getting. But I've got to. He wasn't in for the treatment. So now that I'm home, I'm going to get on the portal and get him to tell me, what the actual dose was and what this stomach cramp, muscle cramp, if that's a side effect, which actually just started about a half hour ago.
Okay. Well, let me just check in quickly with Debbie. How you doing, Debbie?
She's pulling in a garbage can right now. Hang on a minute.
Okay.
Hang
All
on.
right.
Hello. Anyone there?
I just want to know. I am here, and we just want to check up and see how you're doing. Are you feeling better?
I am feeling better, thank you. Yeah, it's been quite the roller coaster. But yeah, we're doing okay.
Okay. Good.
We're just
That's what I want
yeah.
to hear. So we want you back on. We want you back on that caregivers call so you can tell the ladies, because they worry about you, and you can tell them that you're settling down and you're managing. So come back on that caregivers call with Donna.
I will.
Okay.
I will.
Okay.
Thank you so much.
Pleasure. All right. Well, I'm going to move along because we've got a few people that we want to cover. We'll start with Jake because Len is dark. And tell us what this PSA result is. Jake, are you muted right now?
Yeah, I was. Before we go on, we also have someone on the telephone.
Go ahead.
I just joined us on the phone. I guess not. I guess they're not wanting to talk. Anyway.
Somebody on the telephone who joined us in the last 20 minutes, would you like to tell us who you are, or would you just prefer to stay silent? Okay, that's fine. No problem. Keep listening in. Go ahead, Jake.
Okay, I went to my oncologist on the, I don't know what day it was, about a week and a half ago. My PSA did go up. I was there on the 10th. It went up from 6.0 to 6.9. Curiously, my testosterone went from 39 to 29, which I don't quite understand. I didn't get to talk to the oncologist about anything. I was in a bad mood because I wasn't feeling well. She was in a bad mood because somebody, apparently somebody that was in there before me was anemic and passed out. So I guess they had to do some kind of emergency procedure. So I didn't talk to her at all. So somebody put a smiley face on my mom. They sent me the results, and somebody put a smiley face on it, meaning it's so, it's nothing to worry about yet. So that's it.
That's it. Well, smiley face is all well and good, but a conversation with your oncologist is a heck of a lot better, I would say.
Well, her threshold is 10. Go ahead, Rick. I'm sorry.
Well, yeah. A couple of thoughts. First of all, I think that the variation, testosterone fluctuates. So, 29, 39, it's not a huge difference. It can fluctuate by 100 or 150 points if you have a lot of testosterone. So, that doesn't shout at me. The 6.0 to 6.9 between March and April, my only suggestion here is that you probably would be a good idea, and if it were me, I know that's what I would be asking for, is to have a threshold when you know you're going to intervene.
Well, right, and we've talked about that before. Her threshold is 10 or increased pain. And, she always asks me, do you have any additional pain? And I say no, and so she said, okay, well, we're going to continue with the present course. But like I said, we didn't talk at all. She took my blood pressure and walked out because I think she was still upset about the guy that had passed out from the anemia right before me.
Okay. Len, what about your blood counts, by the way? Were they changed up, down?
No, they were pretty much okay. Most of them were in a normal range. My glucose is always a little bit high, 102. My A1C was 5.1, which is great. My triglycerides were a little bit high, and my HDL was a little bit low. Was low. My HDL is always low. But everything else was pretty much in range, which, you know, and I've told you that before. My blood results, they fluctuate. They one day one month they're low, and then the next month they're high, and there's no rhyme or reason from what I can tell.
Right.
This time they were pretty much.
And where are you with the statin? I can never remember. You are on a statin, aren't you?
Yes, I take atorvastatin, Lipitor.
Right. Okay.
Yeah,
you know, that's also a possibility, is to switch. I mean, I've known people that have switched their statins and they have had results with that. So if you like grapefruit, you could switch to rosuvastatin, and then you could eat grapefruit as well.
Yeah, I know you.
That makes a difference.
I was actually on before I was ever on Lipitor.
Oh,
and
okay.
It didn't work. We're talking many years now, but it didn't really work that well for me. My
Okay.
total cholesterol.
Just a thought.
Yeah, my total cholesterol was 147, which is right in the mid-range.
Well, that's pretty low. Yeah, that's great.
My triglycerides.
Len, what do you want to say to? Since we finally got him to at least tell us what's going on, we extracted that information out of him.
Yeah.
6 to 6.9.
You didn't call on me.
I'll take the responsibility.
I wanted to ask Jake, has your testosterone always been in that general region of 30 or 40, even though you're still on enzalutamide and Lupron, right?
Yes. Yeah, my testosterone never went below 20, 25 actually. Oh. But ever since I've been on the Lupron, it's been between 50 and 25.
Well, Lupron, yeah, but even after they added enzalutamide, it still never went down below 10, for instance.
No.
That's pretty unusual.
Yeah, I'd have to look at my results, because I keep track on my computer, but I'd have to look. But as far as I know, it never went below 20. I don't know if the enzalutamide had an effect on it or not.
Yeah. And what is your hemoglobin? Do you know what that is? You said all your other blood values were normal.
Yeah.
And I would think that someone like you who's been on ADT for quite a few years, that it would start to bring down your hemoglobin and hematocrit like we saw with Peter.
You don't mean the hemoglobin A1C, you mean the...
Yeah, regular hemoglobin.
Yeah, hang on.
Or hematocrit, either one.
I didn't know there was going to be homework here. My hemoglobin is 15.0. Normal range.
Wow.
Normal
That's
range.
amazing.
Why is that amazing?
It's amazingly good, yeah.
13 to 17 is normal range. Hematocrit is 43.6. Also about mid range.
Yeah.
So, like I said, all my readings were in a normal range this time, except for my glucose. So they always say, "Oh, your glucose is high." My age ratio, whatever that is, albumin to globulin is high, 2.3.
Okay.
I don't even know what that means.
It's not clinically significant.
Okay.
So I think it must be all the exercise you're doing, Jake.
I think so. and my good diet, and I know that's why my triglycerides are up, because I eat too much junk. But yeah.
It was that pizza pie that your son brought over a couple of weeks ago, and you got right over it. That's what it was.
Yeah, what it
All
might have
right.
been.
Anyone else?
It might have been right before I went to her to have my blood drawn. I'm not
There
sure
you
when
go.
it was.
There you go.
Yeah, well, Rick, just one more thing I have for Jake. So she has set this milestone at 10 for your PSA. Did she say what she wants to do at that time?
Yeah, her next thing is probably Zytiga. She made the point that she says to me, "You've always been a good responder. We'll try Zytiga next." And I told her about the 10% thing, which you kind of ruined my day when you told me about that. But I mentioned that to her, and she goes, "Yeah, well, you might be part of the 10%. You've been a good responder."
Well,
she has never mentioned apalutamide.
The good news about trying Zytiga for you is with your T level being as high as it is, Zytiga will almost certainly bring that down below 10. So that may have a positive effect in bringing your PSA down. What do you think, Rick?
Agreed. I
Yeah.
like what you say.
I don't know why I never went that low in the first place. I mean, it's clinically 50 or low or below is was the original goal. Now they wanted 25 or below, or 20 below or below, but mine never went to that point. So, and I don't know why. Maybe
Yeah.
I'm just too macho or something.
That's right.
I overwhelmed the drugs. I don't know.
Well, the Zytiga works differently than the enzalutamide. It will prevent the synthesis of testosterone. Enzalutamide doesn't do that. All it does is block the receptor, the androgen receptor, from testosterone. But Zytiga will actually prevent your body from making testosterone. So that'll lower your T level, and it may induce a PSA decline. And so the other thing I wanted to say, I think there's a general consensus out there now that when something's not working, don't waste any time. Get to the next drug. Don't give the tumor a chance to mutate and get stronger. So, I don't know why you don't start Zytiga right away.
Well, because I'm not convinced that it's not working. That's really why. And she's not convinced that the Xtandi is not working.
Well,
again,
it's working. It's working, but not as well as it used to work.
Well, true, yeah. I mean, at one time it was down to 0.5, so it's obviously not working as effectively as it was.
Right.
And Lupron's not working as effectively as it was either. But were I to stop either one of them, my PSA would go through the roof. I'm pretty sure.
Right. Yeah, but I think that's the point that Len is making is that once you know that the drug isn't working that well, make the change. Don't milk it out. But the problem is that goes against the philosophy of the medical oncologist who has always said you got to milk it to the end. And I don't think that's the thinking. That was the thinking 10 years ago. I don't think it's the thinking now, and I think that's the disadvantage of having a general medical oncologist as your quarterback. But two things are not going to happen here. The first is we're not going to change the mind of his medical oncologist, and secondly, we're not going to get Jake to take a GU Med-Onc on board. So I think we have to recognize both of those shortcomings.
Well, I would look for a GU Med-Onc, but there's none in the area, believe it or not. I mean, there's some in DC and Baltimore, but that's like the other side of the world for me. It's got to be local. Yeah. And I've looked.
There is not going to be one. There isn't going to be one that's local. unless you're really, really lucky. So, you know, the closest to you would have to be DC or Baltimore. Exactly right.
Yeah. So.
And that's what I took into account when I made that statement just now, that we're not going to get you to a GU med-onc, and we're not going to get your med-onc to change her mind. And because she doesn't, you know, keep up with the literature the way that a GU med-onc would.
Right. Yeah, that
Anyway,
does bother me about her, and I get a little bit aggravated with her once in a while, but it is what it is.
Well, that's right. You know what's going on. Len, let's move on to you. You got a report for us.
Right. So just a super quick update on the Gleason 9. Originally had lesions in the bilateral seminal vesicles and a couple of pelvic lymph nodes. Had radiation therapy, and that brought it down to 0.0. It was originally 49, brought it down to 0.1 after radiotherapy and androgen therapy. So let me just jump ahead. That was back in 2014. Jump ahead to 2017, January of 2017. My PSA stabilized at about 0.5 on drug holiday, and it stayed that way for November of 2017. It was 0.5, stayed right around that level to October of 2018. Then it started going up. So from 0.5, it's gone up to went up to 0.68, and then to 0.8, and then to 1.2 in February, and then I just had it analyzed 2 days ago, and it was 1.28. So after ramping up at a pretty fast clip, it seems to have stalled a little bit, possibly. So my oncologist says, let's continue to be on active surveillance, wait and see, because I'm on a waiting list for the NIH to get what is supposed to be the most sophisticated scanning agent called F18DCF-PYL. Supposed to be at least as good, if not better, than the gallium-68. So I've been on a waiting list now for about 3 months with them. I can also get that same scan in a clinical trial at Yale, which is closer to my home in Connecticut, but they won't take me unless my PSA is 2.0. So I'm kind of sandwiched between waiting for NIH or waiting for my PSA to rise to get into the Yale scanning trial. That's about it. All my other blood chemistries are normal, although my hemoglobin and hematocrit is not quite as good as Jake's. I don't know how you do it, Jake.
So mine will be different next month.
So for those of you who cannot see Len right now, I want to know, did Dr. Rowe ask you how you had such a wonderful tan?
Oh yeah, he knows I was down in Florida.
Okay.
Yeah, he's very jealous. And he complained about the bitter cold. He complained about the bitter cold winter that he had to suffer through.
So anybody want to, I mean, this is a great story of Len's, because we're looking at somebody who has been on a drug holiday since November of 17. Isn't that right, Len?
No, actually, since January of 2017.
Since January of 17. Wow. Okay.
But it started, it was going up until November of 2017. And then it went up to 0.5, and then it stabilized for the next year.
Okay, so you started this in January of 17. Oh, that's right. I see. You visited with Dr. O in December of 16, and he agreed to a holiday. So we've seen all of 17, all of 18. So that's 27 months of drug holiday, correct?
Right.
So for those of you guys who are on the call and listening, it can be effective. It can be a very good strategy, and we've got the living proof in our resident pharmacologist here. So
keeping in mind,
course,
everybody's
of
different.
course, Richard. I have lots of questions.
Okay.
No Lupron.
Well, go ahead, Ken.
No Lupron. Absolutely nothing, Lynn. Right?
Absolutely nothing.
Absolutely nothing. And you didn't have a PSA rise. You went on a drug holiday. What do you think if I asked Dr. Korn to go on a drug holiday? What do you think he'll say?
Well, I forgot, Ken, where are you right now in your PSA?
My PSA right now is 1.27. I've been on Lupron for 2 years and 4 months. And my PSA, I don't know, I'm scheduled to go for a new labs. I'm scheduled to go when I get back to Arizona on the 27th. And I don't know, I'm anticipating a rise, but I was on Casedex for, 2 months, and I must admit I got a little advantage out of it, but it stopped working last month. So I just decided, with his consent, I decided to take a little, per se, a holiday. No Casedex, but I'm still on Lupron. But I'm anticipating my PSA to rise from 1.27 to like whatever. But I don't know. I think he'll say I'm absolutely bloody nuts if I ask for a drug holiday.
Well, he may tell you the same thing Dr. O told me. He says, well, let's try putting you on Zytiga to see if we can get you down to 0 and then go on the drug holiday.
I haven't done, Rick's been pushing apalutamide, so well, I've been telling Dr. Korn that that's the next drug I'd like to start to take, and I know it's going to lower my PSA like crazy. It's going to take me to the tank because it's my second life androgen deprivation therapy, but it's all about buying time.
Right, but as we alluded to earlier, Ken, most of the med-oncs these days believe in starting the second line hormone therapies right away. Even before
I didn't do that. I did chemo. I did chemo and irradiated my prostate, so I didn't go that route because that wasn't what they were saying at the time I got diagnosed, or at the time I was going through these protocols.
Oh, I know. So, and the same is true for me too. But now they're saying they're giving Zytiga, or they're giving enzalutamide, or they're giving apalutamide right up front. And the clinical trials.
You're saying go ahead and jump on those and get my PSA low, and then see about taking a drug holiday. They're
Talk it over with Dr. Korn.
I know he's not going to be too keen on it. My oncologist in Arizona is going to be like, "No, are you fucking crazy?"
Has there been a standardized set of qualifications or what have you for an individual to go that route?
Well, what was it, the Latitude or the, I always confuse them. There's the Latitude trial and the Stampede trial. They gave Zytiga and they gave enzalutamide right up front with guys even who were either, well, they might have been metastatic, Rick. Is that right? in those trials?
Yeah, they were. Yes, they were.
Well, then you are metastatic, aren't you?
Depends how you define metastatic.
I know. Don't go there with me. Don't go there with me. You either are or you aren't. I mean, if you have it outside of the prostate, you're metastatic. I don't give a shit.
Okay, fine. Then I'm metastatic.
Okay.
Yes, you know, Anderson's been talking to me for too long. Anderson, where the hell are you, by the way?
Right now I'm up in Washington State. I'm at a house that I bought when I was 18. I rented it out for years and years and years. In fact, the girl that cut my hair when I was like 5, she rented it for years when I was in college. And I decided like 10 years ago not to rent it anymore because everyone trashed it except that lady. So I decided just to come up here. Last week, I must tell you, I retired. I closed my office.
Okay. I knew it was
closed
imminent.
it. I know I closed it, but I didn't. I took your advice, though. I didn't tell everyone that I closed. But anyway, let's get back to Lynn. Let's get back to Lynn.
So let me just put let me put 2 cents in here. I think the really big difference for me is that, Ken, when you got diagnosed, your PSA was 1,919.
No.
1,900.
No, you got someone else. My PSA when I first got diagnosed was 537, and 20 days later it was 729. But I went on Lupron, and it went to like 50 the first 30 days, and then I went to like 2 the next 30 days.
Oh, I know what I'm looking at. That you had in 1999, you had very high PSA, correct?
I did. You're right. I did because I had prostatitis.
Yes. That's what I got. Now I see. So you were 526 and 729, and you were diagnosed with metastatic prostate cancer. So when you started, it was clear that it was already in your bones.
Yeah, I had 5 lesions.
Right. And having said that, and Len, on the other hand, when he was diagnosed, was highly suspicious of having disease in his lymph system.
Oh, I got it. There's a difference.
You both were diagnosed with metastatic disease, but your metastatic disease was a lot more advanced than Len's had ever been. And to me, whilst I think that intermittent hormone therapy can work for people, Peter Kafka's another guy. But with Peter Kafka, who's had success, we've never really seen any bone metastasis. We know it's in his lymph nodes. And what concerns me is that men doing intermittent hormone therapy, when we know that the disease has spread that far, may not have the level of success. And I think that's where, to me, that's where the difference lies. Len, what would you say? And then we'll go back to Ken.
Yeah, I agree completely. I was not aware that Ken had bone metastases. If I did also, I'm not sure I would be on intermittent therapy. I'm not sure that Dr. O would have allowed that. So I understand why your doc is reluctant to allow you to do that, Ken.
Anecdotally, this is Jake. Anecdotally, I also have bone mets.
Hey, Jake, we know when you talk.
Oh, okay, good. I guess that's good. For people on the phone. But anyway, I am metastatic, bone metastatic, and I talked my doctor into intermittent hormone therapy right after the Maha Hussein studies, and she goes, "Well, I don't think it'll work, but we can certainly try it." And it did not work for me. My PSA started going up real quick. So
yeah, I know you had mentioned that, and I'm quite confident mine would as well. You know, if
Yeah.
I went off Lupron, I think mine would go through the roof.
But I mean, you know, you can try it. I mean, you know, in fairness, I went off of it and it stopped
Just for
working.
grins or what? Just for grins or
No,
what?
Well, I responded very quickly when I started back on the Lupron. I mean, it started going up very quickly, but then as soon as I started it, went back down again.
Right.
So, it was almost like there was no break.
I got you. But you guys get back to your normal call. I'm sitting here with some friends. We're all listening to you. So get back to whomever's next.
Oh my goodness. Let me just tell you one thing before I didn't realize that we were stars today. And Anderson, do me a favor, give me a call so we can catch up sometime soon. But I had the opportunity to speak to the president of Janssen and a couple of other fairly high-level people when I was in Dallas last weekend. And I pushed him hard to try and do a monotherapy trial of apalutamide alone based on Al-Fat's experience and a couple of other people. Now, I will say that Al-Fat, his disease is much closer in history to Lenz, from what I remember. I mean, I don't know, I'd have to look up, but I'm not sure that he actually has bone mets. But the reason I said this to him is that, you know, I don't think there's a man in the country that wouldn't want to try monotherapy apalutamide if they thought that they could get high levels of testosterone and still control their disease. I mean, that's sort of the dream of most men with advanced prostate cancer, wouldn't you say?
No, I would agree that if I could get off this testosterone dropping drug and maybe even get back to 100, I'd be happy.
Yeah. Well, we are, you know, we're pushing it, and we'll see what happens. But I think it's going to be a while. But anyway, all right. That was a great. Hey, was there? Before I lose you, was there anything
like
else
30 minutes.
Okay. All right. Was there anything else on your mind you wanted to raise? That's all I was going to ask you.
No, I'm good. I'll send you a note here after I talk to Paul when I get back into Phoenix on the 27th, and I'll let you know what he says.
Okay, I'm just looking. Yeah, so Al-Fat did have a bone met, but it was after a while, and he wasn't diagnosed, I don't think, with a bone met, but he doesn't have extensive bone mets. So, I mean, that's sort of relevant if we talk about the apalutamide monotherapy without any LHRH drug. I'm going to keep pushing on that because I really would like to see, I'd love to see that trial happen. Let us, I think, go to Larry Fish for the last 15 minutes because I think everybody else, is there anyone other than Larry that wanted to get in today and hasn't had a chance to get in? Okay. You got the last 15 minutes, Mr. Fish.
Wow. So, I mean, partially, I think this might be more, to some extent, appropriate for Jake's, for the emotional call, but it's also clinical. It's the concept of things that happen to your body that can be, the emotional side, extremely scary until you can figure out what it is that's happening. Like that relate to your prostate cancer or Lupron or your other conditions, and how that you can freak out over that, and how I did a couple of weeks ago. And I'm still not down to earth on it. But the issue is talking about, in this case, like male breast cancer as a increased potential for people who've been on Lupron for a long time. So I had a scan a few months ago, 3 months ago approximately, that showed increases in what were very small tumors or were growths in my breast, like 2 were almost undetectable, but 1 had grown prominently, it doubled in size over the year. And I brought this up. We went and the report said, okay, can't just recommend like watching it, maybe rescanning in 3 to 6 months if you see anything, just to be sure, in 6 months. And so I went to see my my regular Lupron shot and my med oncologist, and she said, okay, let her try to feel it. And so she tried to palpate it and found it. It was pretty deep, and she said, okay, I'm not really concerned, but let's keep our eye on this for your next Lupron shot, which is next week or 2 weeks from now. And let's see how this goes. I don't want to treat anything about it right now. And I was fine with that. It seemed like reasonable, and she wasn't worried about it, although I didn't ask her why she wasn't worried. Then, a couple of weeks ago, I was lying in bed on a Friday night, and I started to feel my tissues and found 3 real lumps, and that this lump has really grown a lot from whatever it was, where I used to have to dig pretty deep to even think about finding it. And I remember I put up a note to myself like about 3 or 4 months ago saying breast lump ? And now I came and I see these things are really growing clearly. And Saturday and Sunday I decided, and I looked it up, researched it on Saturday, and by Sunday I was totally freaked out. And imagining how are they going to treat this combination of problems, and imagining what the fuck. And then on Monday, I couldn't wait for this 3 more weeks, so I called my primary doctor and I went to see her, and she felt these things and said, I just think it's encapsulated fatty tissues. Fatty tissue. You can cure it for $3. Try duct tape, meaning stop eating. That's her usual. Said, can you give me weight loss pills? And she said, no, for $3 you get duct tape. But that's like her hard work philosophy. But all the other ones have not worked for me. But anyway, so it was this terrible scare. And I wonder, we never really talked much about male breast cancer. And her idea was that these felt soft to her, and that cancer is usually hard, firm and hard. And so she really thought it was fine. So I calmed down, but not until I see my oncologist will I really feel better or get another follow-up or do something or biopsy or something. I don't know. Apparently that needle biopsy is pretty. She said she didn't want to send me for a sonogram since I had an appointment in a couple of weeks, and not to really worry. That's where I'm at. I'm not really worrying, but I don't hear us talking about that much. That's why I brought this idea up.
I'm really glad you did, and I think it serves us well on a whole number of fronts. I think we owe you a debt of gratitude, Larry, seriously, for raising issues like this. No, seriously, and let me tell you why. Because I listen regularly to that to the Male Breast Cancer Coalition call, and a lot of guys on there, they never expected to get diagnosed. They did get diagnosed, and they've had a significant amount of treatment. And it's not something that we as men look out for. We don't self-examine. Although if you go on the Male Breast Cancer Coalition site, they encourage all men to self-examine. And I think that what you're doing is smart, and I am concerned about the way that your PCP disposes of it, because it isn't a joke. And this weekend in Orlando, the Male Breast Cancer Coalition is actually is having their conference. And if I had you talk to Peggy Miller, who leads their effort, her son Brett was diagnosed very young with male breast cancer and is still very active. She'd tell you in a heartbeat, no, so, when you next go, and I don't mean this to scare you, and she's probably right. but it's not something we should dispose of. I have not heard of an association between Lupron and male breast cancer. I'd like to ask anybody else if they have. But I think there is some sort of connection between Lupron or LHRH drugs, I should say, in a wider context, and the buildup of fatty lipids. Does anybody else know anything about, can anybody else throw any light on that issue?
I've never heard about Lupron increasing your risk for breast cancer. Larry, are you BRCA positive?
No, I'm not.
Well, that's a good sign. As far as your PCP checking you out, did she ask you if the lumps were painful or not?
Yeah, she did. They were only painful after she dug in there to find them.
Right.
She said that might be a good sign also.
Right, exactly. I've looked into it a little bit, and apparently there's, and I don't know which is which, but when if the lump moves around, and if the lump or stays in the same place, or if the lump is painful or not, are indicators of whether it might be breast cancer or not. And it might very well be that by doing that, she decided it was not an issue with you.
Well, that's what she was thinking, but she did want to keep an eye on it, but we didn't rush. She said, I don't want to rush to treat you yet. And we have the 3-month appointment is coming up, and I'll bring that up, and maybe we are going to do biopsy just for safety's sake.
You said they saw it on a scan. Did they do? Was it like a mammogram, or just a regular?
Well, I had my regular CT and bone scan, and they compared. It didn't show up especially. She didn't think especially cancerous, but I'm surprised because I thought like the contrary. Does that mean there was uptake? I didn't get into that discussion. What did I want to say? So I'll know in a couple of weeks what her next opinion is, and I'm thinking maybe I should just get they say needle biopsy is pretty simple, and now that it's clear, and wait for, rather than scan, just get the big one biopsy and see what the story looks like. It's like 3 or 4.
So,
I'm not gonna, the
when
one
you
is
say a couple of weeks,
well,
when you say a couple of weeks, Larry, is that with Dr. Altio?
Yes, it is.
So, to me, I think that I would feel much more comfortable if she decided that it wasn't worth biopsying than your PCP, because even though this isn't her field, she's in a very fine hospital, and she's more likely to have experience of this happening, and I think they're going to be a lot more cautious than your PCP is.
Yeah, well, it was more about seeing my PCP to calm me down a little bit until I saw Dr. Audio. She works with a bunch of breast cancer specialists, triple negative specialists, breast cancers. They do a lot of stuff in research in common. So I'm sure she's pretty hooked into the prostate breast cancer at Sloan. She's pretty hooked in. She does research with Radcliffe,
exactly.
another. So she's pretty up. But at the same time, I really noticed a lot of growth, which did. That's what I wanted to mention. The reason there might be some like 5% increase in male breast cancer for people who've been on Lupron is because of the size of the breasts increasing, and the amount of just the general amount of breast tissue leads to more tissue for cancer to have an option for. Something like that. I can't find some research, but nothing really clear.
Okay. Well, I was going to say, if you found any research with that, I would we'd all be very interested to see it and to hear about it. So don't hesitate. Meanwhile, did you spend the $3 and buy some duct tape?
No, absolutely not. I've been that rich, and I don't even believe in the duct tape method. That's like, you know, the Russian method for drug treatment is just throw you in a cell and don't give you any drugs for like 3 months.
Nice. Okay.
That's
All
her.
right.
She has that philosophy. I love her, but she's
Okay.
she doesn't.
I didn't think you had, but had you done so, I was going to ask you what color you bought.
I didn't. She like her philosophy about prostate cancer and slightly rising PSA is just sit quietly. Oh, first, be careful when you cross the streets. Watch out for the very little things. That's what you have to worry about. And sit quietly, and you'll watch the funerals of your enemies pass before your eyes. That's like some saying. And don't worry. That's her usual answer.
I see. Maybe we should pair her with Jake's oncologist.
But if there's something, you know, like something specific, and she acts right away. But in general, about the large, anyway, that's another story. Okay, so that's just where I'm at, and maybe I'll go back and look at the research again. But first, I'm going to wait a couple of weeks. I don't want to go.
Yeah, please do. But thank you. But you know, guys, please raise stuff like this. Don't think that it's not important. I mean, you know, it is important, and it's great to discuss this stuff, and for us to focus on it a little bit and see what we come up with. Don't shortchange yourself on these issues at all.
Yeah, no, I felt comfortable. Anyway, okay, thanks, guys.
Thank you. All right, well, we are at time. Small group today, but we certainly had a couple of really great discussions. I think the discussion on the intermittent hormone therapy was a highlight of this call. I think we talked about it and got to had some pretty good insights about intermittent hormone therapy. Next week, we actually don't have a meeting because it's a 5th week. So as I mentioned right at the beginning, we will have that 9/11 session, which of course everybody's welcome to. And I please encourage you very much to forward that information along. We do have a web page for it under plenary sessions already. If anybody wants the flyer, just send me a note and I'll send the flyer to you. If you've got any friends who are first responders, please let them know because they should spread it around in their community. And it can be little stuff, as I said, anything from as small as sleep apnea to stage 4 cancer can be eligible for compensation. And then our next meeting will be the 6th of May. Yeah, our next meeting will be the 6th of May. I will talk to you all before then and stay in touch. Don't hesitate to be in touch if something comes up that you need some input on between now and then. All right, I'll say good night to everybody. Anything, Len, anything you want to say? Anything else?
Nothing to add, Rick. Thank you for the session. Good night, everybody.
Good night, everybody.
Good night. Good night. Good night.
Good night. Thank you.